Good evening, ladies and gentlemen. This evening we're reporting 40 new cases, bringing the total number of cases to date to 26,838. We're also reporting one additional death, meaning the total number of deaths to date remains at 1,774. Over the past 14 days, 898 cases have been notified, giving a 14-day incidence of 18.9 per 100,000. Of these 898 cases, the median age is 33 years, with 73% of cases occurring in people under the age of 45. 59% of cases have been in men, with 41% in women. 37 cases, or 4%, have been in healthcare workers. 329 cases, or 37%, were in Kildare, with 150, or 17%, in Dublin, 105, or 12%, in Offaly, 70 or 8% in Laois, and 40 or 4% in Limerick, with 32 or 3% in Clare. The remaining 172 cases were spread across 20 counties. In relation to clusters in residential care facilities, there have now been a total of 483, of which 272 have been in nursing homes. These clusters have been associated with 7,594 cases across all residential care facilities, of which 5,876 have been in nursing homes. There have been 1,118 deaths associated with outbreaks in residential care facilities, accounting for 63% of all deaths. And of these, 995, or 56% of all deaths, have been associated with clusters in nursing homes. There are currently 13 confirmed cases in our hospitals, 6 of whom are in our critical care units. I'll just hand over to Professor Nolan now.
Okay, so very quickly then, we are in a situation where we have, over the last 2 weeks, had a very sharp increase in the number of cases being reported per day, with a spike a few days ago, 174 cases. And we'll look at it in a bit more detail in a minute, but that means this week, this Wednesday, looking back 5 days, the average number of new cases reported per day was 75. So that's a very significant increase on the period in June and early July. The other metrics of severity of disease are stable. I've noted last week that the number of inpatients in hospital has stopped declining, so that was progressively decreasing. It's now, the average is hovering just above 10 at 13 over the last 5 days, with typically 1 admission per day. The number of people in intensive care remains very low, on average 6, and 1 or 2 admissions every 5 days. And typically we will be confirming, sadly, 1 death here per day, even though many of those confirmed deaths will relate to periods several weeks back. So large case numbers, stable hospitalizations at very low levels, stable intensive care occupancy at very low levels. In terms of the testing regimen, we've seen a shift in the testing regimen over the last couple of weeks, where the pilot of serial testing in nursing homes was paused for review and will begin again, I think, quite shortly. And of course, there was an uptick in testing associated with control of these very large outbreaks in the Midlands. So over the last 5 days, about 4,500 tests per day, and we're detecting more cases with those tests. So the positivity rate has gone up from about 0.5%, 1 in 200 tests being positive, to 1.7, close to about 1 in 70 tests being positive. Now, obviously, that's a very low positivity rate. It implies that your testing regimen remains robust, but we need to keep a very close eye on that level of positivity to see it doesn't increase further. So looking a little bit more carefully at the cases per day, that you see up to the 29th of July, we were very stable at typically fewer than 20 cases per day on average, increasing very quickly then associated with these large outbreaks. And over the last 2 days, on the one hand, you may think the numbers are low when you've heard numbers like 100 or 170. numbers like 40 seem low. But if you look back over that chart, you have to go all the way back to early June before you see 40. So it feels like a low number. That's only because of what's been happening in the last week. That remains 2 to 3 times higher than we were typically seeing on an average day in late June, early July. Where are these cases occurring, or sorry, how is the disease being transmitted? So we do know, and we obviously have been watching this very closely, that we have these large clusters and outbreaks and are concerned to ensure that we don't see associated community transmission. 70% of the cases over the last 14 days are in those clusters. And because of that, and also because the test and trace mechanism is so effective, the vast majority of cases we're detecting now are traceable. They're close contacts of another case, whether that be in an outbreak or in a household or in a more localized setting. So 71% are close contacts of confirmed cases. There's very little in terms of travel-related or healthcare required. And if you look at the dark grey on the bottom there, the y-axis is number of cases per day on average. So still in terms of community transmission, we're seeing fewer than 10 cases per day as confirmed community transmission. The light grey area is cases where we can't trace the origin, so that's possible community transmission. And some of those recent cases on further investigation will be linked to an outbreak or to another case, so that will diminish. But over the last 2 weeks, only 16% of cases are confirmed community transmission, and only 6% of cases remain under investigation or assigned possible community transmission. It's important to say, I think, that of the cases that we're looking at, the commonest form of cluster is a workplace cluster, or also importantly a household cluster. So 45% of all cases are either in workplaces or in outbreaks in households or extended families. Final thing I want to show is obviously we're monitoring very carefully the incidence by county. So this is a heat map going right back to the beginning of the pandemic in Ireland of incidence by county. So green reflects very low incidence. In order to remain green here, you have to have an incidence of fewer than 5 per 100,000 population. And red and darker red means very high incidence, up to above 200. And what this highlights is that the 14-day cumulative incidence remains very high in Kildare, Laois and Offaly. You can also see, that's towards the right-hand side of the chart, that a number of other counties are experiencing smaller outbreaks. So you can highlight Clare, Limerick, Donegal, Wexford, Carlow. Those incidences remain between 5 and 15 per 100,000. But so it indicates that we have two issues going on here. These very large clusters, which in Kildare, Laois and Offaly, which the very specific measures so far seem to have prevented any onward community transmission. But we also have smaller clusters, much more widespread in the country. So the message remains right across the country that the basic physical distancing and hygiene measures required to prevent onward transmission from those smaller clusters really need to be reinforced. Finally then, last week we reported the reproduction number as being around 1.8, which is worryingly high. The estimate this week, it's very difficult to estimate reproduction number where you've got a mix of outbreaks and some disease in the community. This week's best estimate of reproduction number is that it is around 1.6. The confidence intervals are very wide, and that's because case numbers are increasing or decreasing day by day. So that uncertainty is related to the fluctuations in case numbers. It's very much driven by the outbreaks, so estimating reproduction number under these circumstances is not particularly valid. And if we look at the isolated cases alone, it's even more difficult to estimate, but it looks like the reproduction number more widely in the community is lower and closer to 1. Thank you very much indeed.
Okay, Zara King, Virgin Media News, good evening. Dr. Glynn, we can see from the data that there's an average of around 6 cases of community transmission over the last week. I think there we said 16% is confirmed as community transmission. What proportion of these do you hope to identify as part of known clusters, or will many remain untraceable? And just, I suppose, is that number of community transmission cases a concern to you?
So any community transmission is a concern, but I guess throughout the course of the last number of months, we have always had a proportion of cases, and you will always have a proportion of cases that are defined as community transmission. It is a concern that we have community transmission, whilst the overall proportion has stayed relatively stable, or in fact perhaps even decreased a little, given the intensive work that's ongoing around following up cases linked with the clusters that we know about. The absolute number of cases which have been defined as community transmission has gone up as part of the overall rise in cases over the past couple of weeks. So we are keeping it under review. What's of at least as much concern is the increase in number of cases generally. So it's good that we're able to link them, but they are still cases. Each and every one of them is still a positive case, which in a situation where we're not necessarily suppressing this disease means that there's potential for onward transmission to other people. And we're seeing a number of other counties, as Professor Nolan has shown there, where we are seeing an increase in cases. And so the message, very understandably, the message is centred around Kildare, Laois and Offaly. But really, we need to reiterate again to people across the country to follow the advice.
And as you mentioned there, a general increase of cases is a concern. I know we're going to see from government a new roadmap published over the coming days or weeks, but I suppose what is an acceptable number of new confirmed cases on a daily basis when it comes to this idea of coping and living alongside the virus? I know yesterday you said let's not get bogged down in day-to-day numbers, but just, I guess in general for people, I guess the public sometimes will panic when they see a number jutting up. I mean, is there a base level where we go, okay, this is acceptable, we don't need to panic, this is expected and it's a normal rate? And what is that normal rate, do you think?
So first and foremost, our overall intention is to have as few cases as possible. Because as we've said, for every case, there's a possibility and a likelihood of further cases. There is no acceptable number, but what we can do is look at trends over time, and clearly the trends have gone in the wrong direction over the past number of weeks. That's not surprising. It's not unexpected. We released the country from a very harsh set of measures. And so it's not unexpected that as people begin to move around more freely, as people congregate with one another, that we will see an increase in cases. But we need to keep the overall number as low as possible on any given day. It is important, we set out at the start of this process to be as transparent and as open as possible and to give people as much information as possible. And that's why we release the figures every day. It's why we give as much information as we can every day. But it's important, I guess, that people don't put undue emphasis on either a low number on a given day or a particularly high number on a given day. It really is the trends over time that are of the most importance. So
would you advise people maybe to look at that 14-day instance as a good benchmark, because perhaps 14 days is just a better way of examining it?
So no measure in and of itself is perfect, and there's certainly there are weaknesses inherent in that as well, but it does give people a better picture of what's happening in their area.
Okay. And just in relation to the localised lockdown we're seeing in those 3 counties, I mean, what is the criteria in terms of lifting that lockdown? Will it be case numbers? Will it be sort of localised or number? I mean, what is the actual sort of, what determines whether it's lifted? Because, I mean, presumably if the numbers are higher in 2 weeks' time, does that mean an inevitable staying in lockdown for another 2 weeks?
So again, in the first instance, when we make recommendations, it's about a whole number of different factors coming together, and it's the context in which those factors and that evidence is coming together. So a key part of our recommendation last week was that we hadn't seen community transmission, but we felt that the volume of cases at the time and new cases emerging rapidly pointed to a situation which, if it continued on that trajectory, would have made community transmission inevitable. And so we felt we had to move in advance of that. Now, we're just to be clear, we're still not completely confident that we've avoided community transmission. We simply won't know that until next week. And as I've said, over the course of this week, we are likely to see days with numbers that are significantly higher than those which we've reported today. And again, what's important for us is that we look at the trends over the 2 weeks. So there won't be just one figure that we look at, Zara, to answer your question very simply. I don't know if Professor Nolan wants to add anything to that.
I mean, very briefly, it is about the 14-day incidence. It is about whether the 14-day incidence is increasing or decreasing. If your 14-day incidence is increasing, it's a much more dangerous situation because it implies there's a force of infection behind that pushing the 14-day incidence up. And then, is there community transmission or is there a risk of community transmission? And is there any evidence that the disease is hitting vulnerable populations or creating disease of such severity that people are being hospitalised? So I'm really only reiterating that things like localised reproduction numbers and so on are not particularly useful. You have to look at the full array of metrics and use public health judgment to understand is this a dangerous situation or a situation that's under control or a situation that is being suppressed.
Okay. Can I just ask in relation to the situation in Naas General Hospital, I understand the testing is being carried out on people working in the ward there and a number of doctors who would move between wards. Is there plans to carry out sort of that idea of serial testing within the entire hospital? And if not, why not? Because clearly we do have capacity in the system to do that type of testing. Would it not be prudent to do that?
The testing in Naas General Hospital was very much directed by the Infection Prevention and Control and by our public health colleagues. So they did very much a risk assessment on where those particular cases were. And obviously I don't want to say too much to breach anybody's confidentiality, but the decision was made to test appropriately. And if people feel, anybody who wasn't tested feel they have symptoms or have concerns, they can contact IPC, Infection Prevention and Control, or their occupational health department about that.
Finally, one really quick one. I did have a query from somebody, Dr. Glynn, this is more of a specific issue, but it was somebody who was working as a childminder in a home with a number of children that she felt were displaying symptoms, and the parents were reluctant to have the children tested because they had sort of relayed to the healthcare, or to the childminder, I should say, that they felt that children didn't need to be tested and know they were all right. And the childminder was very concerned about this, and obviously this is their work environment as well. I mean, do you have any advice for people in relation to children displaying symptoms? Should they be going for testing? I mean, there's sort of a miscommunication, I think, or a little bit of confusion around children and COVID, and what should be done in terms of testing. Perhaps you could just give some clarity on that.
So I'm not going to speak obviously to a specific situation or a specific set of symptoms, but if parents or carers have concerns, in the first instance they should call their GP and have a discussion about whether or not a test is needed or warranted. We do want people to have a low threshold to make that call, because what we don't want is people of any age walking around with this disease and potentially spreading it to others. Just specifically in relation to children, there has been a very significant amount of work done over the past number of weeks by colleagues in the HSC and in collaboration with ourselves in NEFIT. And we will be giving further consideration to testing pathways, protocols for testing, who should be tested, when a test can be avoided, and the development of specific guidance and communications for parents and carers. So all of that will be part of our discussions at NEFIT next Thursday, and I'll certainly intend to give more clarity following on from that discussion.
Okay, thank you very much.
Hi, Shane Beattie from News Talk. When did the person die who's in today's figures?
A couple of weeks ago, Shane.
And I know there was another death earlier in this week as well. Are they recent deaths, or because I know there was some historical deaths with this? Was that another recent one as well?
I don't have the detail of that one, but in the main, over the past number of weeks, the deaths that we've been reporting in the main are from earlier parts of the pandemic.
NEFIT met today, I understand. What was decided, or was anything decided?
Nothing in particular. Today was largely about understanding the evolving epidemiological situation. We had an extensive report on the ongoing clusters and response in the Midlands. over and above that, really, it was just looking at the contact tracing and testing pathways, as we do every week. So that we'll have a much fuller agenda next week, as I said, in relation to guidance and protocols around children in particular.
And the colour coding response, how far away are we from that?
So NEFIT did very extensive work on the development of a future framework from a public health perspective throughout July, and we would have submitted the framework from our perspective for consideration by government earlier this month. So the framework really sets out, from NEFIT's perspective, a lot of the learnings, the principles upon which we believe we need to move forward now. It sets out the kind of key indicators that we use when we're considering measures or release of measures or imposition, recommendation for additional measures. And it really aims to give people some certainty in what is a very uncertain situation. But a key part of the framework, and I think a key part of the future steps and the future approach, will be that COVID is with us for the coming months at least. It can't be just about NEFIT or a public health response. As we've said here many times, we're not the experts across a whole range of sectors. And so we've developed our part of the framework, submitted it, but now it's being considered across all government departments, so that what comes over the coming weeks will be a holistic and whole of government approach to future phases.
So you're finished with from a NEFA point of view, with the colour coding recommendation. Now it's up to others to decide to implement it?
So we've made recommendations from our perspective. Of course, as other government departments and as other sectors consider it, there may well be a need for nuance or clarification, but we've certainly submitted a significant document for consideration by the rest of government.
Okay, two other areas, just on the issue of pubs. We've both vintners groups now out saying today they're not optimistic they'll be allowed to reopen at the end of the month. Do you share their pessimism about that?
So I'm not going to speculate on that. I know it's a very difficult time for them, but as with any set of measures that we have to recommend or consider throughout this process, we haven't speculated a week or 2 weeks in advance, and I'm not going to do that tonight.
Okay, and in the other area of schools, the Taoiseach Leo Varadkar has said that he can guarantee there will be clusters when schools reopen at the end of the month. What are you saying to parents and to schools? Can you guarantee that there will be clusters?
Well, I hope there isn't clusters, but I've said here previously, I think there will be clusters, there will be cases. It's virtually inevitable, because this is an infectious disease that spreads when people congregate, when people come together. But everything is a balance of risk. So schools have been preparing now for a number of months. There's a whole range of measures that need to be put in place. And again, we're not the experts on the education environment, but I know the Department of Education and schools have been working really hard on this to minimise risk. But there is no zero risk environment. And it is likely that there will be cases and clusters, unfortunately. And we'll have to respond to those dynamically, as we do in any other sector. But balance that against the need for children to have an education. And in light of guidance and what we know about children, not that children have no risk, as I've said. If children need to be tested, they need to be tested, and we'll give more guidance around that next week. But we need to balance the risks in relation to the infectious disease versus their needs as children and the need for educational attainment and development.
Okay, and that would mean then that it's not inevitable that if there's a cluster that the school would have to close down, because children are slightly different when it comes to COVID. Is that fair to take from what you're saying? So with any environment, whether it's a factory or a school or a home, when there's a cluster, our public health colleagues in the HSE will risk assess and contact trace, identify close contacts, and we'll have a low bar for testing and for implementing any other measures that need to be implemented to protect public health. So there won't be a blanket approach that says close every school once there's a case. There may be schools that need to close. We saw that
at the beginning of this process, and that may need to happen again. But the hope would be that in the main, through the measures that are in place, so there's lots of measures in place around minimising movement between classes, for example, so that if you do have a case in a class, hopefully in terms of close contacts, it would only be the other children within that classroom, for example, that might be defined as close contacts and therefore might have to restrict their movements.
And just one other question to do on schools. It's to do with the area of school uniforms, because there's conflicting advice. Some schools are saying that they're not going to bring in a school uniform for at least 6 months because they're telling parents that the uniform would have to be washed every evening. Then other schools are saying that there's no issue with the school uniform, that they don't have to be washed every evening. And parents are now wondering, do they need to buy several uniforms, or will there be no uniform? Can we just get some clear advice for parents on school uniforms?
I'll ask my colleagues who are preparing the advice about that particular issue and how often the clothes should be washed. So I haven't heard that particular conversation myself, but I'll certainly follow up on it, Shane. Yeah.
So do you know, where would schools get this notion to tell parents then? It's not from public health anyway, you're not saying it.
So I'm not aware that it's in the guidance that's been issued, but I will follow up on it and I'll come back to you on it.
Great, thank you very much. Thank you.
Fergal Barrows, RTE News. I know, Professor Nolan, you're talking there about there's very little travel related cases. To what degree are you reliant on people being honest about their travel history in terms of nailing that down? I mean, for example, people coming into the country, maybe developing conditions, not identifying that they've travelled abroad, and others. Is that an issue?
I would say, Fergal, that the response in its entirety to this pandemic is dependent on people's willingness to be honest, to put their hands up, to come forward for testing, to isolate when they've got symptoms. And the vast majority of people have done that to date, and that's why we managed to get this under control. Ultimately, the success, insofar as there has been success in relation to this to date, has been premised on the actions of individual people around the country and what they've done. A key part, I guess, of people coming forward is that they know that no blame is attached. Again, as I said previously, any one of us can be diagnosed with this disease. Any one of us can get this disease despite taking all of the measures that we talk about. There is no zero risk environment. You can take all the measures and still be unlucky. So there should never be any blame or judgment, and I'm quite sure that if someone comes forward and says that they've been abroad or they've been, at a house party or whatever, there will not be judgment. Our doctors, first and foremost, want to protect the person, protect their contacts, and isolate them and prevent further spread. That's what our response is focused on.
And in relation to colour coding, I know you said you sent in a framework sort of outline for that, and it'll be up to the government and others to come to a view on it. Can you point to where that type of system, the colour coding, in other countries works well? And for example, how often might it change? Would it be daily? Would it be weekly? Or what could you expect? Would you have to every morning look at a colour coding change?
No, I wouldn't envisage it changing that rapidly. I think it's been well aired that there's 4 phases. So there are 4 broad sets of criteria. But within that, there will be particular indicators that we look at. There will be a set of measures. I guess I'd describe it as a menu of measures that might be recommended within a given context and set of indicators. People should be able to look at it on any given day and understand the current situation in the country. But that's a different thing from suggesting that the colour will change every day. This is dynamic, but it's not that dynamic.
Okay. And then finally, just in relation to children, I know you made some points there last week about the risk of spread in relation to children. What reassurance can you give to parents? I get a lot of communication, I'm sure my colleagues do, from some parents who seem quite anxious about children going back to school, and maybe not so much it's being spread between kids and kids themselves getting sick, but maybe kids coming back home and their parents or older relatives contracting it. Because I know in America in 2 weeks in July, 100,000 children were confirmed as having COVID-19. That's according to the American Academy of Pediatrics. So I know there's always some risk level. So what reassurance can you give people who are really anxious about their kids going back to school, given the point made even this morning by the WHO that schools have to reopen, it needs to be done, and there may be outbreaks, but it's an essential part of life?
So I suppose I'd reiterate that there is no zero risk environment. There will be a proportion of children who are diagnosed with COVID, as there has been to date. I suppose the first piece of reassurance I'd give parents is that the vast majority of children who are diagnosed with this disease suffer at most very mild symptoms, and in fact we believe that many children who contract COVID in fact have no symptoms at all. So that's the first piece of reassurance. The second thing I'd say is that we're not powerless. Parents aren't powerless. Children aren't powerless. Schools aren't powerless against this. There are many things we can do to reduce the risk of transmission. And we need to have a real focus on that over the coming weeks. And that applies to the school environment. Equally, it applies to the home environment. And what I'd say, again, is that the single biggest predictor of how this will evolve when schools reopen is how this disease is circulating within our communities at the time. So there's a very understandable focus on meat processing facilities at the moment, on direct provision centres. There was a very understandable focus on our nursing homes and residential care facilities. There will be a focus on our schools, all of which is entirely understandable, but all of which perhaps at times detracts from the key message that the greatest protection any of us can give to any one person in those settings is to ensure that community transmission is kept as low as possible.
Thank you.
Hi, Dr. Conor Gallagher with the Irish Times. Just in terms of those clusters you talked about, are there any new significant workplace clusters or categories of clusters outside of the ones that have been well documented in the meat processing plants that have given you concern in the last week?
So I suppose significant is a subjective term. There are a small number of other workplaces, particularly in the three counties, that have had a small number of cases, and appropriate public health actions are being taken at the moment. I wouldn't categorise any of them as unduly significant at this point, and the number of cases really is too small for me to. I wouldn't like to comment publicly on any particular one of those. As I said, to my knowledge, there's less than 5 cases in any one of those, so they're all being actively followed up by public health colleagues in the HSE.
Stephen McNairn with the Journal.ie. There's a bill that's been put forward in the Dáil, essentially asking to make workplaces notifiable to the health and safety, or that workplaces notify the health and safety authority where there's an outbreak. Is that something that NEFIT would recommend, or do you have even an opinion on whether it would work?
I think, being honest, I think that's probably beyond the remit of NEFIT. From our perspective, the medical officer of health legislation and our public health doctors work under that legislation. Clearly, we worked very closely with the Health and Safety Authority, or at least our colleagues in the HSE have worked very closely with the Health and Safety Authority over the past number of months. But I think your question is more a matter for the Health and Safety Authority in the first instance.
Okay. I'm wondering, would Philip kind of have a breakdown of the 898 cases in the last few weeks, where there's like how many were close contacts, how many were travel, how many were clusters, and so on?
Yes, we do. 70% of them are in clusters and outbreaks. 71% are close contacts of confirmed cases. 16% are confirmed community transmission. 6% possible community transmission. There's an important thing about travel. Only 2% were imported cases, whereas about twice that, about 4%, are travel related. So that portion is a very small fraction of the overall.
Are there overall figures available for the amount of patients that we know are asymptomatic?
That's a changing. That's a changing picture. Globally, throughout the pandemic, the best studies would show that about 40% of people are asymptomatic. However, when you move in on a cluster or an outbreak, you tend to find people, because you're doing systematic testing of everybody who might have come into contact with the disease, you tend to find a higher proportion of people, up to about 60% or even higher in some cases, that are asymptomatic. Some of those are genuinely asymptomatic. They will never have symptoms. And some of them are pre-symptomatic, come back a few days later and they have symptoms. So typically 40 to 60% of any group or any outbreak that's well studied are going to not have symptoms at the time you study them, and at least 40% of them will not have symptoms at any point.
Just one final one for me, for Philip as well. We saw throughout the kind of height of the pandemic, when there was national restrictions in place, that you had modelling data on what the situation would look like without those restrictions. So we saw the two curves, and one was higher and one was lower. Was there one of those done for the 3 counties where there's restrictions in place now?
No, it wouldn't really be a good way to model that. There's a separate process going on with a very talented group in Technological University Dublin that are looking at more localized models of disease. But that's not the kind of decision that a model would be helpful with. That was a public health designed intervention to prevent onward community transmission.
The reason I ask is I'm curious to know, like, do we know or do we have any indication how far the virus would have spread if those restrictions weren't in place? Is there any modelling data done on that? Or?
No, and in one sense it would be somewhat speculative, because you have to assume how are people mixing, and if those assumptions are just a little bit off, then your model is quite a distance off. So when you get down into quite localized settings, smaller numbers, the assumptions become more important. So that's one of those circumstances where no amount of calculations is going to help the chief medical officer make a recommendation. So no.
Why is that different on a larger level? Why is it like why are you able to say do it on a national scale as opposed to a localized level?
Basically, you're averaging out your mistakes over a much larger population, and the whole population is behaving in similar ways. So if we wind back to March, April, the virus is very prevalent. It was spreading quite openly in the community, whereas go back a week or 10 days, the prevalence overall is low and the outbreaks are contained. So you'd have to go in and model the plants and the factories and the community in extraordinary detail, well beyond the sophistication of the national models that we have earlier. So those kinds of models in those kinds of details are inherently more unreliable than a population average model, which is what we were using when the whole country, so to speak, was in trouble.
Okay, thank you.
If I might just on that, and it's separate but related, is because it comes back to our decision making and some of the commentary since that. So I know that one of the comments that I've heard made on a number of occasions is that our use of the 3 counties was a blunt instrument, and I'd agree with that. It was, but I think there may be a misperception out there that all of the cases are located very close to where the processing facilities are located. And we can see that that's not the case, and so I just want to use this as an opportunity to remind people across the counties that the measures apply across the counties for a reason. And so we've seen cases, for example, over the last 14 days as far west as Birr, Ferban, Clara, Tullamore, over to Eatonderry, Maynooth, Clane, Newbridge, Athy, and down to Abbey Leaks and Durrow. So I just wanted to, I suppose, to highlight the fact that people work in a particular place, but they live and socialise and meet people in communities and towns and villages all across those counties. And indeed, I also want to get the message out that it's not just about those counties. If you live in an adjacent county, and I've been clear about this, there's nothing magic about a county border that protects you if you live in 1 or 2 miles just over the border. So really, I'm just anxious that the national message and the need for national solidarity and the need for people to adhere to the public health guidance nationally doesn't get lost in the very understandable focus on these 3 counties at the moment.
Just on that very last thing you said about adjacent counties, what sort of down, or why was there not necessarily lockdown restrictions put in place, say, in those counties? Like, could you specifically link the cases in the 3 counties to people who, so, like you say, like lived in the towns that you just named or socialised in the towns you just named, but that because there wasn't necessarily people living and socialising in those adjacent counties, is that why they were not put into lockdown as well? Or
So this is, again, it's about risk reduction and risk mitigation. You can't eliminate all risk. And of course, what's happened will have increased to some extent the risk in adjacent counties. But given that the vast majority of people working in these facilities, over 90% of people working in these facilities, live across these 3 counties, we felt that it would be proportionate. And it was based on the evidence and the evolving volume of disease and picture of disease as we saw in the surrounding counties as well.
great, thank you.